All right, Helen, can we maybe move to our first slide? This is Margaret Burkhardt. I'm the president-elect for CHASM this year, and I'll be doing the introduction for our Return to Sport and Exercise Medicine Practice webinar tonight. I want to welcome everyone who is here tonight. I think we're going to have an excellent panel of 5 speakers presenting to us. I think because we have 5 speakers and we are hoping to take questions, I expect the running time for this webinar might be around an hour and a half or so. I'm hoping that our speakers will each present for about 7 to 10 minutes or so maximum. And the plan is to take all the questions at the end of the speakers' presentations. So we'll do all 5 speakers and then we'll take all the questions. I encourage anyone who has a question to pose it in the Q&A section at the bottom of the Zoom page. And I will try to collate those as we go along, and I'll present them at the end. We have a set of questions which people have already submitted at the time of registration. This webinar will be recorded, and it will be posted on the CHASM website. There's a new resource on the CHASM website. Actually, if you were to go to the website and hit the resources button on the header, and in the drop-down menu, you'll see a new page called the CHASM webinars, and you can find it there. Also, this webinar will be emailed to all of the attendees who've signed up tonight. So there are no official CME credits for this webinar tonight, but I'll remind everybody that you can actually submit for self-learning or non-credentialed credits for this kind of thing. And without further ado, I'll introduce our first speaker. And the first speaker is Rich Trenholm. Let me just go here. Rich practices family medicine with obstetrics, along with sports medicine in Huntsville, Ontario. He has served on the CHASM board in the past, and he owns and operates a busy multidisciplinary rehab practice in his community that services a large catchment area. And with his family practice, he's been in operation since the start of the pandemic and has a good grasp on what works and what doesn't work with regards to patient flow, precautions, and office procedures. So Rich will be talking to us about the return to multidisciplinary sport medicine practice. Rich?
Thanks, Margaret. I'm hoping this works. Let me know if you can see my slides. Okay, so I'm going to be talking on creating control from chaos, the multidisciplinary clinical approach. And like Margaret had mentioned, I have been working in the environment with COVID precautions since the beginning, since a family practice didn't close up shop. So, you know, it, in all honesty, took a lot of open communication within the office to talk through this with the staff and with the providers within the clinic to make sure that the things that we're doing worked. What didn't work, what was good for patient experience, what kept the patient safe, what kept us safe. So some of the things, even though it doesn't necessarily show up in the guideline X, Y, or Z, I would think that this comes with a bit of practicality. So hopefully I can share some of what we've learned works and doesn't work with you guys tonight. So, you know, I like what most people are doing for patient flow in the pre-clinic situation. At the time of booking, we're asking patients to get onto the Government of Ontario or Ontario government self-assessment tool to do the pre-screening. It does just speed things up because people are people understand what the questions are when you do go and repeat asking them the questions again. When you send out a patient reminder, because a lot of clinic EMR systems are able to send out a reminder text or email or both, and you can embed a link in there to have them go to the self-assessment tool just to ensure that they are indeed still screening negative. Prior to arriving, having a sign on the door that has the questions. We've got a 24/36 poster just right outside our front door so that people can quickly visually scan just to confirm that they are screening negative. It's useful if you have the means by which to have a single point of entry, single point of exit within your clinic. Most people have a front door. And it does take a little bit of ingenuity and creativity to have people flow in and out of the office in a circular fashion. We have a 5-minute rule at our clinic. You're not supposed to show up 5 minutes before your appointment, and if you're 5 minutes or more late, we ask that you be considerate to the next people in line and rebook your appointment. I found that that's worked quite well. People are quite understanding, and if you pre-warn them that this is the way that we need to operate for now, they understand, and it's not much of an issue. You know, even though we work in it every day, you have to be conscious of the fact that this environment is new to them. They're used to going to the grocery stores, but they're not used to coming to our medical clinics and how this works. They're very afraid, most of them, to come to our clinic because they think that it's a COVID-infested environment, when in fact, most of the time it's the cleanest place that you could actually go. And it's reassuring if you explain that to them. So most colleges, the physiotherapy, chiropractic, massage colleges are advocating for wearing masks. Some patients are bringing their own. You know, we have a variety of masks available for people at the clinics. We usually provide the first one free, and if they forget it the next time, then we ask them to purchase one, or they can purchase one. I've got a couple of patients that are sewing masks, and they have them individually wrapped and heat sealed, and all the money goes to our local hospice. So it's if that's, you know, if that's available to you, that's a good way to kind of flow money through to a local charity that needs it. You know, it's strongly suggested that the providers wear surgical masks for their time that they're providing, but it's not necessary for a patient too. If you've got your staff behind one of the sneeze guards, it's not necessary that they wear a mask unless they're coming into face-to-face contact with a patient. I think this is out of line, I'm sorry. One thing that we've started to adopt, especially with physiotherapy and chiropractic, is for just the initial consultations. We do a virtual appointment, and that actually lets people get in a little bit quicker into the clinic because you've gone through all the questions and you've done kind of a movement screen, and then you just have to do a targeted exam once their visit starts. A couple of clinics, I just haven't put mine up yet, but it's nice for you to do a little handheld iPhone video tour of your clinic, just so they know what it looks like and what to expect, and what you're doing to make sure that they stay safe. So when somebody comes into our clinic, we've got a hand washing station. We've got the hand sanitizer at chest level. Reason being, we had it on a little coffee table and people walked right past it. So it does have to be in a very visible spot. We've got a sign there that says how to wash your hands with the hand sanitizer. I recommend 15 seconds to do front and back and in between the fingers. And we've got a little clock there just to show them what 15 seconds is. And then they have follow the leader. We've got, actually, to keep the sport theme, we've got pylons set up going to the desk with a checkered finish line at the desk, so they know where to stop. We get people to pay before they play, so they pay for their appointments before they come into the clinic, so that when their appointment is done, there's no coming back to the desk to socialize. So they have to. You want to keep the interactions brief and on time, and minimize that usual little bit of social time that happens in the clinic. In the reception area, we've got a rather large sneeze guard. We've got a card swiper for the Ministry of Health cards that the patient can swipe themselves, or some clinics are doing a visual inspection, so they just show their card up to the sneeze guard. There's a couple ways you can operate the debit credit machine. Just strictly tap, or you can take an added level of precaution and put a little piece of saran wrap over the top and just change it out if they use the keypad. You can buy fancy things that you wipe down, but I found that the saran wrap works quite well if you buy a big jumbo roll from Costco. We try to operate in as much of a cashless system as possible, but if cash is required, we get the patient to provide us exact cash, put it in an envelope, and we quarantine it for 14 days. So the big wipe down, we found that using the single-use wipes, we were creating a lot of garbage and using a lot of paper towel. So we have one of our local breweries switched over to make sanitizer in a spray bottle. And so we are using the washable, sorry, my kids are coming into the house right now. They're, we use a washable sanitizer with a spray, and we bought a bunch of microfiber cloths with that we spray down, and we throw, it's a single-use cloth that we throw in the laundry and we wash it at night. What's touched by the patient or the provider needs to be wiped down. High-use items need to be wiped down after every patient contact. So like treatment tables, chairs, rehab equipment, diagnostic equipment, therapeutic equipment, door handles, point of sale machines. Low-use items need to be done every half day, like computer screen, mice and keyboards, cell phones, sink taps, handrails on the front desk, and protective screens. So we have our front staff go around and do that. And that's all I've got, because I know I was on a timeline and I think I just did okay. So anyways, I'm gonna pass it back to Margaret.
Thanks, Rich. Yes, it's an excellent overview of clinic, starting the clinic running. Our next speaker is going to be Dr. Andy Marshall. Andy, as many of you know, Andy, he's an orthopedic surgeon and owner of, one of the owners, co-owners of the Carleton Sport Medicine Clinic in Ottawa. He has been Chief Medical Officer at the 2016 and 2018 Summer and Winter Paralympics, and is the current CMO for Tokyo 2021 Paralympics. He is the chair of CHASM CPD Committee, and as of 1st of July this year, he'll join us on the CHASM Board of Directors. Woohoo! Andy will be talking about return to orthopedic sport medicine practice.
Hi, and I'm going to apologize straight up. I got caught in the COVID Rogers internet fiasco in that they won't upgrade my my internet, so I'm at best coming and going. So I'm going to spare you my my visual. And some people say I have a radio face anyway, so I probably better go this way. So I'm just going to go a little bit through what the problem is and then what we can do. Certainly from a clinic point of view, very, very similar to Rich, where we have just started our clinic back up and basically could read the template from exactly what he was doing. So the problem we have is that pretty much all elective orthopedic surgeries were shut down on the 16th of March or thereabouts. And many places were still in this position or recently just started. There are some places where they're at 10%, 20%, and then gradually ramping up, but certainly not close to what we were doing. We know that during the lockdown, the only cases we were really doing were emergencies, and that was mostly fracture care. It's interesting that we saw a lot less hip fractures and a lot less fractures from trauma because people weren't out and about. And even in the nursing homes, that people were locked in their rooms. They weren't going to the cafeteria and pushing each other over. So it added insult to injury in that we couldn't even get the hip fracture people to come in and see us. The people that did come in and see us, unfortunately, many of them were in residences where there were COVID cases or the patients, in fact, were COVID positive. Once they came in and had their surgery, they're stuck in the hospital without the ability to return. At one point, we had almost 10% of our beds in the hospital taken up by individuals that were just waiting to go back to residence or long-term cares. And we also have no ability to go to convalescence during this time. So that's another factor that's impacted our ability to do things. And during the lockdown, what most of us have done is a hybrid virtual care as well as some hospital care. So much like Rich, we kept our outpatient clinics up and running for the fractures, for urgent cases, but we did have a very reduced capacity. So what that ended up happening was we added patients to the wait list, but we weren't able to remove any from the wait list. So the other thing that we did find is that many of our waitlist patients went from coping or just hanging on, and this is really present in the individuals waiting for arthroplasty surgery, to individuals who aren't able to cope. Pain control as well as non-op care became vastly increased, and we'll talk a little bit about that later on when we talk about injections and other therapies that we've been doing. The other, I think, big group that's are at a deficit here is the complex care individuals. Individuals that couldn't get into therapy, couldn't become involved in multiple needs, and they weren't able to access some of their caregivers at all in some cases, or only virtually. And they really have shown a lot of degradation over this 12-week shutdown. So right now, MSK surgery hasn't been given a high priority in most regions. In some places, they kept doing cancer care as well as other surgical cases, but in a lot of cases, they even shut those down because the hospitals just shut down altogether, except for ICU and urgent cases. Most hospitals are starting to gradually ramp up, but that's not going to happen. It's not like we've turned the tap back on. Some of them are going at 10%, some of them are at 20%, and the plans are to go over weeks to almost months to gradually get back to 100%. The other thing that looms in their future is both the summer planned shutdowns, and it's hard to tell nurses that have been working hard doing a lot of other things, the rest of the care team in the hospital, that, well, you know, your surgeon's been sitting around doing nothing, now he wants to work, but you can't have summer holidays. So that's a conflict that's going on in the hospitals, and we're trying best to do what we can for everyone to get some cases done, but also to be respectful to the rest of the healthcare team. The other thing, of course, is the threat of a second wave. And as we all look towards the late summer and early fall, there is concern that we may be shut back down to the same situation that we had. So people are rather apprehensive. A couple of studies that were done have, during previous pandemics or hospital shutdowns, have shown that every week that an OR is not operating, it takes about 4.5 weeks to recover. So at this point in time, to recover, we're looking at between 12 and 18 months. The other problem in Canada, at least most of Canada, is that we don't have the ability to expand our OR time utilization unless we're going to start to work evenings or weekends, and that's certainly been proposed in some places. And the other issue is bed utilization. The Ontario government came out and said that we had to have 15% empty beds in our hospital. That hasn't happened in probably 50 years. And certainly to restart surgery, our usual bed utilization is somewhere between 97 and 105%. So it's a big issue that's going to be haunting us as we go forward. So the ways that we look at to optimize MSK surgical care is to continue to maximize collaboration. The great thing about my situation is I work with a group of primary care MSK specialists, and what they've done is they have seen patients, they've continued to do some virtual and now in-person care, and they're helping with some of the non-operative aspect, as well as to help prioritize the urgent cases. Because that's the one thing I have found as I've started up, is that the locked knees, the individual that's lost their range of motion, or that's had, in some cases, some fracture that they were too afraid to come to the hospital or go to the emergency room, are showing up with complications, and some of them have been up to 8 to 12 weeks. And now all of a sudden we have this really urgent cohort of individuals which need care, sometimes surgical. So they're also going to bump some of the individuals that were waiting on the wait list that have also started to decompensate. The other thing I think with the complex care patients, we really have to optimize working with our non-surgical colleagues to try and give them the best care. And if and when they do have to go back to the operating room, such as a frozen shoulder or which we don't really do anymore, but someone who's lost their range of motion and needs to have a manipulation under anesthesia, we have to make sure that we can get them physically into physio, because there's no use in operating and then not having that care. And the other thing that we are starting to do, and it's a bit of it's unfortunate that we have to do this, but we know in Ontario that individuals got care in terms of having their joints replaced by advocacy. And that was putting pressure on the government as well as the local healthcare, the LHINs, for MSK care. And I think, unfortunately, we're probably going to have to do that to help to catch up on, to prioritize some of the MSK cases to gradually move forward. So that's what we're doing at this point in time. And certainly we're looking for any inventive or other ways to try and increase our ability to catch up on the long waiting lists that are there and will continue to be there for a while. So I think that's my last slide. I just, can I give you back the screen?
Okay.
Yep, there you go.
Great. Thanks, Andy. Thanks for that talk, for helping us to understand a little bit better what orthopedics is facing as this COVID pandemic rolls out. Our next speaker is Terry DeFreitas. Terry is a sport and exercise med doc at the Glenn Sather Sport Medicine Clinic and an assistant professor within the Department of Family Medicine. She has a special interest in ultrasound-guided procedures specific to sport medicine. And she's currently working as team physician for Taekwondo Canada and FC Edmonton Professional Soccer. And Terry actually is going to speak to us about considerations for sport medicine procedures.
Thank you, everyone. I'm just trying to share this screen with you, and we'll get started. So. Just wanted to talk briefly about sport med procedures and just get into the normal slideshow here. There we go. So before a procedure is proposed, there's a series of thoughts that go through our minds, and it starts with what's the level of risk in our province, what's the level of risk in my region, and do we have adequate screening to identify patients at risk for COVID, just as our previous speaker has identified, and then also the consideration of what type of procedure might this be, so urgent, semi-urgent, or elective. And for the most part, sport medicine procedures would include joint injections, trigger point injections, possibly PRP, ultrasound diagnostic in a limited capacity. So the first thing that we should think about is, can we talk to the patient first virtually and discuss why they may want the procedure, what is their current pain levels, and what are they very high risk? Are they high risk? Is there people in the home that we have to be concerned about that may be at high risk? And then the patient's current pain control options. Have we maxed out on medications? That sort of thing. Have they completely stopped their exercise routine because of COVID? And then what is their current function? And will the procedure improve that function? So at the beginning of COVID, we struggled with stopping all procedures because as sports and exercise medicine physicians and as orthopedic surgeons as well, our concern was if we don't do these procedures, their function will deteriorate. And that's really a question that we have to ask ourselves when we're considering doing a procedure, is how significant an effect this might have on function. And then the other thing we can ask ourselves is, can the patient pain and function be stabilized without the procedure? And if the answer is yes, maybe they don't need the procedure at all. One of the things that goes through my mind, and we thought things to consider, is if we don't provide the procedure today, is the patient now a fall risk because they're increasing knee pain or they're increasing hip pain? Is the patient at risk of overdosing with medications due to uncontrolled pain? Is the condition significantly and negatively affecting the patient's mental health? I've certainly had that experience where people's mental health is affected by the extreme isolation, and their worries about their osteoarthritis outweighs their worries about COVID. And the other thing is, do you think the patient might go to emergency if you don't do anything for them now? And that's one of the considerations that we thought would be important in deciding about a procedure. And then finally, does the patient understand the risks and benefits and is able to make a decision and consent to the procedure in the consideration with COVID? I wanted to talk briefly about corticosteroids and COVID. So this has probably been playing on a lot of people's minds. Should I give my patient intra-articular joint injection of corticosteroids? We know that corticosteroids have both anti-inflammatory and immunosuppressive effects. And so these are risks versus benefits in the case of an elective joint injection. We also know that intra-articular corticosteroids, there are less adverse effects compared to systemic steroids. But we also see that cortisol levels can decrease right after an injection, and it would take 1 to 4 weeks to recover. And it does reduce C-reactive proteins. I tried to look up all the literature on the subject because it's definitely a huge consideration for sports and exercise medicine physicians. And the literature is basically coming out day by day, and the articles that I were able to find were not even published yet, but accepted for publication in May. The WHO has recommended the use against the use of systemic corticosteroids for viral pneumonia, which is doesn't involve us much, but it was interesting for me to read that they recommended the use of corticosteroids in antenatal care when there was no evidence of clinical infection. And I wonder if that's the similar thought process where we're considering, well, the person's not affected, they're not infected currently, and the benefit might outweigh the risks by using the intra-articular steroid. They also said that they are prioritizing the evaluation of corticosteroids in COVID, and that's one of their research priorities. So I guess we'll just have to keep our ear to the ground about it. In terms of ultrasound and intra-articular injections, this is a non-aerosol procedure. And so the level of personal protection that we require is less than an aerosol generating procedure. So usually mask, goggles, gloves. And sorry, I was looking at my slide. So basically in the guideline that we have produced as a draft right now, there is some lists of different procedures in which we recommend surgical mask, gloves, and goggles. And that's only for protection of the low probability of droplet formation, as most of the sport med procedures that we do that are non-emergencies are very much non-aerosol generating. And that's it all for me.
Great, thanks very much, Terry. Appreciate that informative talk. Our next speaker on our list is Dr. Tatiana Jevmovic. Tatiana is a primary care sport medicine physician at the Fowler Kennedy Clinic, which is a multidisciplinary academic center in London at the Western University. And as well, she works as an urgent care physician. And Tatiana will be talking to us tonight about considerations for airway resuscitation / CPR procedures in the office. Tatiana?
Thank you, Margaret. I don't have any slides per se, because this is more of a part about raising awareness. It's a situation that we really hope never to be in, having someone collapse in your clinic, whether it's in your office or in the physio area or, front area, but it can happen. It has happened. And so it's a high pressure situation where we tend to sort of turn into auto mode and autopilot. And we resort back to the ways that we were trained. But with COVID, you have to keep certain considerations in mind, and it's been touched upon by Terry around the aerosol producing procedures. And so you have to plan and just be prepared for it. So first thing first, depending on what site you are in, may be guidelines already established that you should familiarize yourself. So for example, some clinics are located in hospitals, and those hospitals may have guidelines, and these guidelines may be specific to that one hospital or to that city, and don't necessarily follow guidelines of other cities, or even some guidelines, for example, of the American Heart Association. So if you are part of a facility where you may have guidelines set for you, you should familiarize yourself and ask if you are not aware, just so that you are prepared. If you're on your own, then you get to set things the way you want. And as I said, there are guidelines out there, for example, the American Heart Association, that gives you some instructions on how to approach it. One thing that's important, obviously, when you're in your clinical setting and someone collapses, the first thing should be, of course, to alert help. So whether it's in 911 or a team in the hospital, if you're part of the clinic that's in the hospital. And then it's getting your team, you should already have planned for this in terms of who's going to respond, but trying to minimize the amount of people that are going to be dealing with the patient that collapses. So again, there's nothing set in stone, but on average, 2 people can usually attend to someone who's collapsed in a clinical setting. And then you can have a third person who's the runner, who can, first of all, they can call 911, they can guide 911 to the patient when they arrive. They can clear the space if there's, let's say someone's collapsing in the physio department and there's a number of people around, clear that space so that you can work without anybody else getting exposed. They can go through checklists to make sure that you are following all the steps. They can help with your PPE that donning, which I'll talk about in a second. Obviously, they can bring you equipment, they can help you out. So make sure you know who's doing what and assign these roles ahead of time so that when it's time to go, you're ready to go. The other important reason to assign people is because you should put on your PPE before you basically start dealing with the person that has collapsed. And so the PPE, it depends on what equipment you have, but definitely should include a mask, preferably an N95 mask, especially if you're going to who needs CPR, plus or minus ventilation. So making sure you have the N95s that fit the members on your team and that they are able to put on and check that the seal is correct. Goggles or face shields or both. London Health Science Centre in the hospital, when a code happens, they're wearing goggles and face shields. So once again, you don't have to have both, but having some sort of protection is definitely encouraged. Gloves, no question. Gowns are highly recommended because a lot of things that could be happening could aerosolize some of the droplets, and so you want to make sure that you cover yourself. And they even, some places recommend bouffants, which are those hair nets, or some sort of hair protection. But again, if you don't have all of this, that's, you don't have to have every single one of this, but you certainly want to have a mask, gloves, and goggles or a face shield, plus or minus a gown to protect yourself. Now, depending on what the situation is, if you don't need to ventilate someone, most of the guidelines will encourage you to not ventilate. You can put oxygen on them. They say up until 6 liters per minute, of oxygen is still considered not aerosol producing. But they do recommend that if you put those nasal prongs, you put a surgical mask on the person so that the oxygen is blowing, but they're still having some sort of barrier. If you're going for higher oxygenation, you are crossing into the aerosol producing phase. And so you should be using a good seal on the mask and a viral filter, so a HEPA filter or something of that nature. CPR, when you hear CPR, some, as Terry said, some references will say that it's aerosol producing. It depends on what CPR is being referenced. So for example, chest compressions themselves are not considered aerosol producing. There could be some secretions coming up, but they're not considered aerosol producing procedures. But the actual bag valve and mask, or any high pressure oxygen, so over 6 liters, any upper airway sort of supraglottic insertion or intubation is considered aerosol generating procedures. So you have to keep in mind that now you are putting yourself and your team at a greater risk of exposure. And of course, this is assuming this person has COVID, which you don't know really. I mean, we screen them. People have talked about screening before they come into the clinic. But you should never just assume because they cleared the screening that they're fine, because I've worked in the urgent care where they tell you one thing and then when you talk to them, they just tell you, oh yeah, well, I'm not really coughing, but I am short of breath, but it's my asthma. And you're just saying, well, how do you know that the shortness of breath that you're having now is your asthma and not COVID? So always sort of err on the side of caution and protect yourself. And if you need to bag valve and mask them, again, make sure that you use two-handed seal on the mask. So you need 2 people, one to hold the seal, so you create a good tight seal, and the other person can bag. And make sure that you have a viral filter, so a HEPA filter or something else around if you're going to be using that, because those procedures, as I said, it can generate quite a lot of aerosol material around that you get exposed. So other things to think about, they're saying oral suctioning is not considered aerosol producing, but deep suctioning, sort of the nasopharyngeal, like down into the trachea, that is considered. Now, that's not something that we tend to do in clinic, but the key is to be aware that you are potentially exposing yourself and your teammates to droplets, aerosol droplets that can basically affect you and make you sick if this person is sick. And so plan to have the right equipment, to have a protocol that you're comfortable with, depending on the equipment that you have, and that you have a plan, a preparedness in place should it ever occur. And hopefully it never does occur, but basically just be aware. That's it for me.
Thanks very much, Tatiana. It's an excellent overview for, I guess, dealing with situations in the office, which, as you just said, we hope we don't see, but we do have to be prepared for. So our next speaker is Erica Person. And Erica is a pediatric sport medicine physician from Edmonton. She's fellowship trained from the University of Manitoba in pediatric sports med and practices in the ambulatory clinic setting, as well as providing team physician coverage for multi-sport games, including Canada Games on many occasions, as well as being a team physician for Skate Canada. And Erica will be speaking to us on the topic of return to pediatric sport medicine practice considerations. Erica?
Well, thank you very much for inviting me to be part of this webinar. Thank you to the attendees for listening. As Tatiana has, I don't have any slides either, because a lot of the stuff that has been covered by the previous panelists applies to pediatrics as well. So I just wanted to talk a little bit about some of the unique features that you may want to consider if you have a significant proportion of children that you do see in your practice. I think the first thing is we got to think about the number of people that are coming to a visit, be it in person or be it virtual. It's not just the child that's coming. They often have a parent or two or four, and they also have siblings. So in some institutions, in the clinical location I'm working in presently, there's a limit on how many patients or how many accompanying members a patient can have. And I've actually had patients turned away because they came with too many people. So right now it's one person. In our province here in Alberta, we've just had some announcements that we're moving to a second stage of opening phase 2. So that may be changing in the near future. But it's caused some concerns with families wanting to come for care, but because they can't bring their sibling with them, they don't have options for childcare. They aren't presenting. So getting to sort of what Dr. Marshall was talking about earlier, are we unnecessarily delaying some of these kids, and what is the morbidity that's going to be as a relation to that? So I think that's just something to consider. If you do see a lot of families having letting them know in advance, if you are seeing them in person, that if there is a limit on how many people that can come with them, if you're working in an institution, if you're working in a private clinic, you may be able to work that around a little bit. Like they come right to the front door and everybody gets put right into the room. So they're not waiting and taking up those seats for limiting the number of people in any one clinical setting. Another thing that you may want to consider in terms of pediatric specific considerations is actually sizes of masks. I've seen lots of kids come in with the masks hanging down underneath their chins because they're too big, and they didn't actually get a pediatric size mask. So that's something to consider. They are made, but something to consider if you see a large proportion of pediatric patients. In the facility I'm working in now, they do provide child size masks if they have enough of them. But ways to get around that is you can actually get the kid to turn the elastic around on their masks to tighten it up a little bit so it's not falling off their face. And also making sure that when they're coming in, making sure they're pinching it over their nose so that it's fitting correctly. Things you may want to consider too is your patients, if they are pediatric aged or even adult aged, and they have certain sensory challenges. I had a patient yesterday that was autistic, and he really struggled wearing the mask. So we talked about how we needed to kind of keep our distance until it came time to do the physical examination component of the session. And then we agreed in a way that was acceptable to him to put it on with his mother's help and things like that. So there's some unique features you may just want to think about if you have a large proportion of these patients, or even are one or two, something to think about that may cause a challenge for you. With respect to other individuals on the panel mentioning the mental health concerns, we're seeing a lot of that. I'm seeing a lot of kids and talking to a lot of families that everybody is stressed. They don't know when their sports are going back. They may not want to go back. They may be in a situation where they're wanting to transition. They don't know what they want to do next, and that's adding stress. Also, in some kids, their sport or their physical activity was their mental health treatment. And now that that's away, how are we going to help manage them and help get them through this? So it's just kind of some things to think about from a pediatric perspective. Something that may be coming up, which I have a little bit of information on, but this is kind of in sort of a very timely topic, is you may have heard the very low but concerning number of cases across the globe, mostly in Europe and the UK right now, of this multi-system inflammatory disease that occurs in children and teenagers after a COVID infection. Initially, they were thinking it was more like a Kawasaki-like disease, a multi-system, but now I just saw a paper today through JAMA looking at how this is slightly different and how the characteristics differ in terms of the age of the patients, what they're presenting with, and the level of care. So that may be something you may be getting questions about from your parents of your pediatric patients. Well, what's the risk of my kid getting this if they get COVID, right? And if they're heading back to sport, which I know is going to be a question we're going to talk about in the Q&A section. But for this multi-system inflammatory disease, it's currently reportable in most provinces, I think. I know here in Alberta it is for sure. So there are case definitions, and we are currently actively surveying intensive care units, PICUs, for these cases so that as time progresses, hopefully we'll get a better understanding of who the kids are that get this, what is their clinical course, how can it be treated, and then hopefully how can we prevent this. So I think just be aware of it. But I think the chances that you're going to likely see that kid with this walk into your sport medicine clinic, probably pretty low, but you may be getting questions about it. So, and I think from my perspective, those are the kind of things I wanted to highlight that may be slightly different in the pediatric population. I know there was some questions submitted about return to youth sports, and I have a little bit on that when we get to that question.
All right, thanks very much for that overview, Erica. That's very helpful. And I think maybe we will just use that as a segue. So we are now going to be starting our question and answer session. We do have a list of questions here, and I'll start with those, and I encourage anyone who has a question to post it into the Q&A section, and I will be looking there, pulling them up as we go along. As a segue from our pediatric section, and this could be answered by any of the panelists who feel that they can contribute, the question was, is there any advice for a return of community kids and youth to sport? Advice from the sport and exercise medicine physician in this COVID time. And anyone who'd like to speak, just raise your finger and off we'll go. Erica?
You want me to start? So I did have a little bit of something prepared, and then feel free, other panelists, to jump on in there. So right now, I think a lot of this is currently in the works, and it depends on your province, and it depends on your public health guidelines within your respective province, and also the sport that you're working with. I know a number of sports are currently working on a return to sport plan. Some are a little bit more ahead than others. But from what I was able to find and research a little bit, there is a CDC, Center for Disease Control guidelines. Yes, it's American, but on return to youth sport, and they rank the different sports with respect to severity levels and risk, from low risk things such as individual running and tennis to high risk things such as football, wrestling. And it sort of outlines some of the things when people are making policy about returning to sport and staged return to sport, things to consider. I think from my perspective, it's really going to be important to be working with your local public health and your local health guidelines, to follow those, to make sure you're following all the current recommendations, depending on your region, with respect to cleaning, sharing balls, how far distance do you need to be, all of that sort of thing. And can you have practices? Can you have games? Can it be how many people? And I think that's going to be very provincially directed. I know here in Alberta, we just had the announcement today, about 6 hours ago, that in phase 2, some team sports are going to be allowed. And so kind of working through that and what does that actually mean? So I think a lot of our provincial sport organizations are working now towards how to get things set up. One thing I wanted to mention, and I'm talking to a lot of my patients about, is the risk of and the fear that what we're going to see, just like Dr. Marshall was saying about some of the people sitting on the orthopedic wait list that are going to be decompensating, or just the risk of everything's going to just kind of come to a head, is that risk of flare, if you want to call it that, of both acute injuries and overuse injuries in pediatric aged athletes. And why we're thinking that is because when things were shut down 3 months ago, some kids may have been in the process of their treatment, their rehab, whatnot. That all got shut down. So they're not getting therapy. Now they're not doing their sports. So they're probably feeling better. And I've had a lot of families, oh, they're feeling great. They're feeling fine. But what we risk is when they go back, like most kids do, they have a trouble going back gradually. It's kind of like 0 to 100 kilometers an hour, and they just want to get there now. But we know that that is a risk factor for injuries in youth, is if we go back too soon, too fast. Another risk factor is that they go back and they haven't fully rehabbed their condition that we were seeing them for to start with. So those are two things that I'm talking to a lot of my families about, to say, okay, we got to make a tempered response to this. We want you to stay active. We just don't want you to be sitting down on your couch playing your video games, your online school and whatnot. We want you to be involved in some sport and activity. We want you to continue your rehab, your physio exercises, even if you have to get that virtually, remotely through your therapist, because deconditioning is real. And I think we see reports from some of the professional sports that have come back. The rates of injury, both acute and overuse, are way higher than anybody anticipated. So I think that's going to bore out in the pediatric population as well. So it's getting that message out to families that, yeah, you're feeling okay now, but caution, we need to we need to make sure you're going to have the right tools in place to stay feeling well.
Thanks, Erica. Does anyone else? Andy, yeah.
Yeah, I just want to put a plug in here. The SMAC group has put out the Return to Sport assessment tool, and as a sort of a outcome from that, we've also looked at and have a tool for club level sports. So I think that, you know, if you're asked to give your opinion, or if you are looking at sports or teams or a club that's to use those resources to help you, to guide you to what you recommend. The other thing is I can every day at this point in time, a different, whether it's North American or European group is putting out their return to play recommendations. And so I think, you know, if you want to get something sports specific, it's there, just Google and research it. If you want to get something that's specific for your area, once again, the final thing is, no matter what, you can't trump the local and the provincial health authorities. So we all want to get back, all our athletes want to get back, but you can't use any of these tools to jump ahead of anything. So just, I know, broken record, but it's important to keep saying.
Yeah, I would echo that, Andy, that when you look at some of these national sporting organizations, if you are dealing with a particular sport, you'll see that they have national, you know, the national organization starts their guidelines, they send it down to the provincial and territorial, they then send it down to the club or municipal level, and it's sort of, the guidelines sort of come down, top down, but they're really implemented bottom up, so that it depends on what your restrictions are in your municipal area, maybe even what the restrictions are in the particular facility that that club plays in, practices in, swims in. You can access resources though by looking in that particular sport, Canadian sport or even international, as Andy said. Did anyone else have a comment to that? No. The next question, which ties into this very closely, and we may have just covered it with Andy's comments, was, as organized sport resumes, community physicians are being asked to look over the return to sport documents. Any particular advice to this? Anything further to what was said? Has anyone been asked to fill anything out for anyone at this point, or we're early days? I'm surprised to see that's.
Yeah, I probably get a lot of phone calls with this, and certainly with the Paralympic aspect of it, we have had a few questions, both nationally as well as internationally. But I think that, you know, once again, I think that the nice thing about CHASM is that we do have that resource out there. There are individuals that are involved in different levels, different sports. And so I would encourage anyone who is asked, and if it's something that they don't feel 100% comfortable with, or they feel there's someone out there that may be able to help them, to share that through through CHASM, and I'm sure people will be more than happy to offer their information, what they've learned with any member that's out there.
Thanks, Andy. The next question, and again, I'll put it out to anyone who'd like to answer. Is there any data to quantify immunosuppression or immunocompromise risk following corticosteroid injection? Has anyone read anything to stratify risk regarding that?
I can just comment. There isn't really a lot of work done on that in the COVID situation. They know that there's studies from at least 10 years ago that talk about cortisol levels going down in a brief period of immunosuppression, but whether that translates to increasing your risk of viral infection within 24 hours or 48 hours, there's nothing published yet on how that relates to the current risk of viral transmission.
Would anyone give particular advice following their cortisone injection? Any advice about what they should or shouldn't do in the COVID, unique to the COVID situation?
So I would say that, first of all, to minimize the risk of exposure, in a month ago, it was go home, stay home completely. And now that things are opening up, I think it's more important for SportsMed to remind patients to not provide themselves with unnecessary exposure, and to also look for the typical symptoms following the injection, and to also, of course, talk about the usual potential side effects and reactions that you might have regardless of COVID. So reaction to the injection, etc.
All right, thanks, Terry. The next question is for clinic owners on the panel or co-owners. Are they providing their employees / contractors with PPE, or are they expecting them to obtain this on their own to work in the clinic?
We're providing it for them. It's an expectation for them to operate within our clinic environment. So that's, yeah, it's quite costly. Like, it's $1.50 a mask, but we're encouraging them to follow the guidelines of wearing the same mask unless it gets soiled or wet. Yeah.
We're doing very similar. I think there are some individuals that, you know, want to go above and beyond and wear a different clothing for every patient. Some of our physiotherapists have sort of come up with that on their own, and certainly we're not providing them with clothing, and we're not, you know, so yes, typical masks. We have some glasses, but a lot of people have brought in their own glasses or goggles that they're more comfortable with. And we do provide, of course, the hand sanitation and those kind of things. But yeah, for all employees as well as the independent contractors.
One clinic owner did express to me that they had a concern that the College of Massage Therapists, and I don't know whether this is a provincial or a national mandate, were expected to change their mask after each patient. Can anyone comment to that? And I know that differs very much from the guidelines that are currently in our hospital for physicians or in the office.
It's amazing the difference in what the different colleges are requiring, and it's hard as a clinic owner to say, you know, which guideline do we follow? And you almost have to fall into the default of going with the most stringent one, but you have to follow some common sense. I mean, we're doing the best with what we've got, and nobody wants to place their patients at undue risk. So, you take the stringent guidelines with a dose of reality.
And someone asked whether we felt that physios should use a gown for each patient along these same lines as they're touching the patient, or and Rich, I know I saw from you there was some good advice you had about short sleeves in the office so you can wash right up to the elbow, and you also had some advice about organizing your clothing for the clinic for the week. Can you speak to that?
Yeah, so I have a set of clothes that I wear to drive to the clinic, and then I change into something when I'm at the clinic, and then I switch back into my home clothes, and I get changed into my, sweatpants and whatnot at home. And then, but if you can keep your clothes at the clinic, then you just take them home in a bag and throw them right into the laundry, or if you've got laundry at the clinic, just as a nice thing for your staff, you can offer to do the laundry for your staff.
Okay, thanks. Let's talk a wee little bit about masks. I've got a few questions here about masks. One was wondering about the appropriate level of PPE for different types of encounters. We've sort of covered this. Are non-medical grade masks appropriate for, like a reusable, maybe washable mask, appropriate for staff/physicians? And I think we may want to actually differentiate between those two. Does anyone want to speak to that? Tatiana, do you have a comment?
Sorry, I was just distracted by my daughter here for a second. Can you just repeat that question?
Yeah, they're just wondering whether, sorry, there were different PPE. Sorry, family. I didn't recognize you were having a family distraction moment. So whether PPE should differ for different encounters, whether, for example, physicians can wear a non-medical grade mask, whether that's acceptable or recommended, whether staff can. I think the OMA has put out something to this effect.
You know, again, it varies so much from place to place. Really, most of the time, a surgical mask for staff is what's recommended. I know our clinic is providing, I know to answer this question as some other people, our clinic will be providing that to all the staff to wear. Gowns and all that stuff, I think that's optional in many like simple clinic settings. Again, it depends on the setting that you're in. If you're in a place where there's a higher risk, you should be donning more advanced PPEs. I was reading there's different levels of gowns out there. In some hospitals like Code Blues, when they're doing them, they're level 3 gowns, and then some other more community settings, there's level 2 gowns. I mean, trying to understand what the difference of those are is you know, you have to do your research and figure it out. I know in our clinic, we're going to be doing basically masks and gloves for regular encounters. I'm not sure about our therapists, whether they're going to be doing gloves or not. I can't remember that detail, but it really varies from place to place. And you know, the N95, obviously, if it's sealed and fitted properly, can be something that can be worn. It's tough to breathe in that thing all day long. Even the surgical masks are, you know, you get hot under there for after a little while, but I don't think there's anything sort of set. Obviously, for the big codes, it's the full-on gowns and everything, but for everyday wearing, I think a surgical mask, gloves, probably a good start, and for everybody.
And Terry?
I was just going to say that in Alberta, they recommend the use of medical grade masks for all clinic staff in the outpatient setting. We're lucky enough, though, that we have primary care networks. So they currently are providing these supplies, but that's going to end soon. But they are saying outpatients, all your staff should have the medical grade masks.
Okay, thanks. We'll just stick with one more question about masks. What is the youngest age for face masks?
So I just looked this up again. Recommendations is 2. Under 2, probably not a good idea for choking hazard, strangulation risk, all that other fun stuff. And also, if the child who is wearing it, for whatever reason, due to age, due to cognitive ability, due to developmental delays, developmental challenges, is going to touch their face more with the mask on than with it off, don't put it on.
Right. Some common sense in there. Next question. Does anyone, and I will open this up to anyone and everyone, does anyone have any tricks for physical exams done remotely, or if there's any resources available for this? Whoever wants to go ahead.
There have been a few seminars that have come out to look at, to do them on the web. I know I've seen some through the orthopedic portals, and I think I'm old. I don't like virtual, and there's something about being able to actually examine patients. So I must admit, I'm very keen on waiting to the days when we can actually see patients and examine them So that's all I've got.
Erica, yeah.
Yeah, I was able to kind of working with a different patient population. When you're doing my virtual visits, I just don't have one person there talking to me. I often have two. So I use it as an opportunity as if I was going to be teaching a medical student, examining a patient for me in the office with me watching them, and talk the parent through it for a lot of things, palpation, using words that they can understand, and then I'm watching them as it happens. Watching them move in terms of their gait if it's a lower extremity issue, watching them do range of motion if they're sitting down. So I've been able to actually, surprisingly, talk parents through a lot of what I can do. Obviously, teaching them to do a Lockman over the phone is impossible. But enough to determine if A, I need to bring this person in to see them urgently because something else may be happening, or do I have enough where I can kind of delay their appointment to when it's appropriate for them to be bringing in for examination. But if you have the ability to have another person in the room, talking them through it, using your skills as a teacher, if we all do a lot of teaching, it's actually been quite satisfying, and a lot of parents have actually really liked it.
That's a good time to do functional movement screening and seeing how people move. Actually, I did a gait analysis on a guy, got him to run on his treadmill at home.
Excellent idea. I've got a question here. Along the lines of return to sport, CHASM outlines the requirement for a certain number of hours of event coverage, both clinical experience and certification through the exam. Do you anticipate an impact on certification for those beginning their one-year fellowship in July? Does anyone feel that they can speak to that? Can Dawn speak to that? I don't know if we've got anyone on the panel who's involved with the exam.
I haven't been on it for a little while. Obviously, that's going to have to be reassessed and looked at in terms, just the same as all the other exams have been either put off, delayed, or Royal College, people have not done their exams and they've been able to practice. So I think that they will have to take that into consideration and look to see if they may have to reduce the hours or something along those lines. I think Tatiana may know.
No, actually, I don't know much more than what you said. I am joining the credentials committee as of the next meeting. I haven't seen any communication about this right now. I think the exam was delayed and postponed, so there's been a lot of work to try and figure out how we're going to run that. But it will be something I think that I have no doubt, as Andy said, it's going to come up. So when we do actually have our meeting, I'm sure we'll discuss that, and there'll be some communication to the membership about how this is going to impact the upcoming candidates for the exam.
Yeah, so I can just let you know that the fellowship committee are actually meeting tomorrow evening. We will discuss the PGY3 fellowship program for the coming year. And as Tatiana said, for the exam, we are hoping that the November 29th dates in Calgary and in Ottawa will be feasible, and we'll run 2 exams on that date. And then we look for the 2021 exam, which is scheduled to be held in April of 2021, April 25th. We'll discuss that at the Credentials Committee in August of this year with the committee. So it's on our radar, and it will be discussed.
Thanks, Dawn. So I'm going to read a few comments that have come in regarding the last few questions that we've answered that I think would be quite interesting for people. Both Lee Schofield, and Laura Cruz have suggested something, www.sportmedschool, all one word, sportmedschool.com. This is a website that has a whole section on virtual assessments. It was Neil Dilworth's initiative. So for anyone who's wondering about assessing people remotely, that sounds like a good site. Let's talk about the issue of masks, when we said about whether you're providing masks for everyone in your clinic and what the different colleges are recommending. We've got Remo Bucci. I'm an RMT in Ontario. It's not mandatory. It's only recommended between patients. he said, and Richard Gowdy said that the guidelines currently in the Emerge that he's working in is they use one mask as long as possible. It was also commented that patients like to see for optics MDs wearing medical masks as opposed to homemade ones, that it's maybe the optics of wearing a surgical mask might be helpful. So I'll throw out those comments. Another question we've got is, could anyone feel capable to address the safety concerns surrounding lactate testing and athletes for CSEP or CEPs? I'm not sure what is meant by that exactly. Does anyone feel they can answer to that? I'm not sure. I'm pretty sure I can't, being honest. All right, well, maybe we can get some answers to that on our chat. I'll keep looking and see. Let's see if we can move forward. Any thoughts on group cycling? This is near and dear to many people's hearts, and I think we will be asked this by patients. Any thoughts on that? What's being done in different provinces? Has anyone heard anything about the safety, efficacy, whether it's cool or not to be group cycling? Andy?
Yeah, so as those that read the SMAC updates, we did publish the information that had come out of the Danish group about the particles and how they do it. And that was, although there was a lot of criticism that it wasn't peer reviewed, we did have our individuals from Cycling Canada as well as from Track and Field or Athletics Canada look at it, and the actual science behind it was quite sound. So I guess the bottom line, if anyone's more than welcome to look it up, and I'm happy to send it out. But the bottom line is you need to give more space. And if you're going to cycle, you should be cycling side by side and not in a pack or behind an individual. So those are the basic, sort of quick outlines from that. So I guess the bottom line is if a pack is 2 people, then you're fine to go in a pack, but really that you should probably try to keep it down to small groups of 1 or 2 and not have large groups of pelotons.
Okay, thanks, Andy. Anyone else to speak to that? No? Okay. Here's a question. It says, why googles, I think it's supposed to be goggles, why are googles, important when we just do echo-guided procedures? What is the risk? So I guess we're referring to ultrasound-guided interventions or even just scanning for diagnostic purposes. Why are goggles recommended? What is the risk? Maybe, Terry, can I ask you about that since you do so much ultrasound-guided stuff?
Sure. If you look throughout various provincial and hospital guidelines for PPE, it varies a little bit, but being overly cautious, like Richard mentioned, the principle is if you've breached your social distancing, you're potentially doing a procedure where somebody might cough or, I guess, yell out in pain. That's the only principle of why you might need goggles for ultrasound guided diagnostics or interventions, really. A lot of the times that is not really a risk. And it's thought that by protecting the eyes, that you will make the physician or the provider a little more safer. That's really the only suggestion. It's not really got a lot of evidence as to how much it really protects you in those situations.
Okay, thanks for that. Now this may end up being directed a little bit towards you as well, Terry, although I'd encourage anyone else to speak up if they know that there's been some suggestion that perhaps there is less immunosuppression post-cortisone with certain types of cortisone, for example, celestone versus depomedrol or Kenalog. And this is referring to that hypothalamic pituitary axis suppression for a few days to a few weeks post-injection. Have you read anything about that to anyone, Terry or others? Can you comment to that? Should we all be running out and ordering Celestone as opposed to Depot? Speak to us.
From what I've read, that has been stated in the literature, but not to a point that it would change practice significantly. I don't think that what I've read, the doses of these different medications compared to each other would significantly make a difference in this situation. I don't know, what do you, and Andy, do you do a lot of injections too? Do you want to?
Yeah, I'm not a big cortisone user, to be honest, but yeah, certainly there was a paper that came out that did suggest that. And much like the original papers that came out of Germany and a couple other countries where they said maybe there's a higher risk of having more symptomatic COVID or worse COVID symptoms in individuals that had been receiving it or had had intra-articular injections. There's been a lot of controversy about those. And so personally, I think, yes, it's something to discuss with patients, but, you know, once again, look at your patient profile. If it's a high-risk patient and from other reasons, they're immunocompromised, they're diabetic, then maybe you should consider putting off that injection. But for the most part, and I don't think I would go out and change what I'm using to reduce that risk theoretically.
Right, exactly. I don't think there's enough evidence to make a big change.
And along those same lines, then, someone's asked, what are people actually saying to patients regarding this immunosuppression risk then with cortisone shots? And how do you document that in the chart? And I think this is a very valid point, certainly I found in my practice. How do you, to the average lay person, how do you explain that theoretical minimal risk benefit sort of thing? Does anyone have any advice as to what they say to the patient and what they document in the chart?
I can say that this has been a very long conversation for the last 3 months that I've had with patients. It helps to understand what they feel is the benefit to them. So certainly people are coming, saying, I really need this injection. I can't function. I accept the risks. So it's really important right now to explain to the patients, we really don't know what your risks are with this injection. And it's a discussion about balance between risk and benefits and going over their particular individual situation, even their family situation and their importance of their functions. So if they cannot function and they're not safe to even go to the washroom because they're limping so bad or they're unsteady, I think that they would be more prepared to accept that theoretical risk of immunosuppression in a few days.
Great, thanks. There's a comment here from David Harrell. Just a comment about the mental health, anxiety, and returning to sport. As a psychiatrist, even though we may not know exact timelines, explaining the known process may be helpful, and continuing open communication is key. And that's an interesting comment, I think, and I've seen that from a couple different sort of viewpoints. I filled out a questionnaire that came online from Soccer Canada, for example, as a parent, and asking about my comfort level with my kids returning to sport. And they're actually asking my opinion as a parent, interestingly, not as a soccer player. How did I think the field should be run? How many kids did I think should be on the field? Which I found very interesting, but did play to that fact that I think that how the parents and the caregivers feel about the kids returning is as important as the true safety factor that we might know is there for the kids returning. And the same applies to, say, university in the fall. I hear parents saying there's no way they send their kid to university this fall, and other people are stratifying the risk differently. I don't know if anyone has a comment to that. it's the family dynamics and it's the mental health of everyone involved. Erica?
Yeah, I would say I echo your comments about parents being asked their feelings on things. I've seen that in a number of other sports, just kind of on some social media platforms, about polling parents. What do you think? What would be your input? But I do think living in these last 3 months with lots of misinformation out there and lots of fear and worry and anxiety, I would just encourage the decision makers and people who are influencing these decisions that you're using solid sort of evidence, if you want to think of it that way, and trying to rely a little bit less on the fear and the anxiety on things when you're trying to come to those. It's hard to do, but I think us as physicians, we can help in that and say, okay, well, maybe you're saying that your child is going to catch, your 3-year-old is going to catch COVID from kicking a soccer ball across the field to the other 3-year-old. Really, the risk is quite low with that. However, if they were wrestling and coughing on one another with one of them sick, a little higher, right? But kind of pointing some of those real facts out and taking a little bit of the emotion and the fear away to reassure families so that they're making the best decisions possible for them.
Thanks. Anyone else to that? No? Thanks, Erica. This is something that, Rich, you might be able to respond to, because I think you do work, or as soon as your 2 clinics will be finished, officially built and finished, you will be working in more than one location. So the question was, is there any guidance for doctors who work at multiple locations? Also, should all office staff be asked to have a COVID test prior to returning?
I would say for the COVID test, no, that's a contentious thing. And I think that's my personal thought is that it's based out of fear mongering. Like, there's no evidence to suggest that people need a screen to go back to work. So I think a dose of common sense exists with working in multiple locations. Like in the morning, I'm over in my family clinic. In the afternoon, I'm over in the sports clinic. And then literally what I do is I do exactly what I said earlier. I have a set of clothes at my family clinic, and I put a set of clothes over at my sport clinic, and I do the Superman change in the telephone booth outside. So that's kind of how I approach it. Lots of hand washing. I do my best at changing locations, but I think from from an administrative point of view, being consistent in the approach in the various clinics certainly does help keep things straight in your mind, and sharing ideas of what works and what doesn't work. Like I said earlier on in my presentation, there's all kinds of guidelines to say, what you should do and what you shouldn't do, but really there's the practical end that you have to take into consideration as well.
Yep, Andy?
I know, I'm sorry, but I'm chirping on everything. But I think once again, as Erica pointed out, common sense has to come into play. If one of those places you're working is in a hospital where you have a ward with COVID patients, yeah, I don't want you to be going there, doing your rounds, seeing patients, and then wandering to your sports medicine clinic in the same clothes. Most places where in the hospitals, we change into scrubs. And how do you have a phone booth, Rich? Like, those things don't exist.
I bought one.
Nice. Yeah, I think that if, working in 2 different places, having a change of clothes in the middle is not an unreasonable thing to do. And, most of us have enough free gear that we've been given from covering events that we can have a shirt in different places. That's all. And I will comment quite strongly on the testing issue, is that, and also give a little plug for we're going to have another COVID talk on I believe it's the 25th of June, through the SMAC group and some of the latest findings, and talk about testing for athletes as well as returned post COVID, positive COVID. But I really, that testing asymptomatic individuals is not an effective process. And I know that a lot of sports teams and a lot of suggestions are out there that they do that, but really they are political decisions, not scientific decisions. And certainly we shouldn't be part of the politics. We should stick to the science.
Okay, I think we'll just have a last question or two. There is a question about what do you do for a patient who feels they can't wear a mask, who says that they have great difficulty breathing with a mask. I'm not talking about the people on Instagram and Twitter who say that they are hypooxygenating with a mask. I think Andy, the surgeon who wears a mask all day in the OR, can probably attest to the lack of science for that. But if you do have a patient who feels that they cannot mask, do you have any option, any advice? Erica.
I would say if it's part of your public health guidelines in your respective region / province that you have to be wearing a mask, then this is kind of like, then the patient, if that's their choice, if they don't have an acute life-threatening event happening right now or limb-threatening event, you'd say, okay, that's your choice. However, these are the guidelines and we have to defer your appointment. It's kind of like the whole thing that's going to come down the pipe with the vaccine and the vaccine hesitant and stuff like that. Is that a reason for not to see somebody, or is there other ways around it? Right. So I think, yeah, that's a difficult one, but I would say if it's current in public health guidelines right now and public health orders to be wearing one, then I think we have to follow those.
Yep, got a few hands. Terry beat Andy by a smidge.
I guess I would be worried about their mental health if they were that anxious about wearing a mask, and I probably would end up seeing them with trying to maintain a social distancing or doing a virtual call at the very least. There are other options. People are talking about getting those little plexiglass portable things and talking to somebody like you were when you see on television people talking to people in prison where there's a plexiglass between them. So I guess there's options. My only concern with someone who says they can't wear a mask is what else might be going on, and that's one thing I'd want to make sure I understood either by phone or by video.
Thanks. Andy, can you add to that?
So first of all, there's many that would argue that probably I haven't had much oxygen going to my brain for a long time. So that may explain a lot of things. The interesting thing, just to be controversial on this one, we went through 8 of the 12 weeks of COVID in Canada where there was no recommendation for general public to wear masks. And now we're going to refuse care to patients because they don't feel comfortable. I personally, I would see them. Yes, I would probably clean that room a little bit more carefully afterwards. But, you know, I think the science with the masks is, especially cloth masks, especially not fitted masks, is not great. So I don't think I would exclude a patient, even if I had that right to do it, just because they didn't feel comfortable with the mask on.
Okay, thanks. And the last is tying in with that, someone asked about, is there any particular guidance about safety to others when training athletes in your clinic? I suppose the person means when you're training the athlete at maximum effort, query risk of increased aerosol shedding of the virus. That person may or may not even be masked in that situation, I guess, even if they're asymptomatic. So can anyone, what would you do in that situation? I mean, physical distancing is obviously something we would, I'm sure, practice in that situation. Is there any other advice? Have you encountered that? Has anyone encountered that in their clinic at this point, or no? Not yet. I wouldn't think so. No, we'll have to address that in a future.
Yeah, I think that there is some, I mean, much the same as the cycling issue, they have looked at, and we do know that the 2 meters is probably not enough in those situations. Beyond that, I think that the science isn't great, and it would depend on ventilation. It would depend on a lot of different aspects, but I'm happy just to have patients in my clinic. I'm not worried about exercising them to the max at this point.
And the last comment was, Andy, can we have a link for the return to play from SMAC? But I think, if I'm not mistaken, is that posted on the CASM website?
It's on CASM website. It's also on the Own the Podium website. And yeah, so, and if anyone can't find it, can't get it, let me know. And I'm happy to send it in English, French, and Russian.
You're so skilled, Andy. It's amazing. I'll take that as a segue. I want to thank all the excellent speakers tonight. You guys put out a great effort and I think gave us a really good comprehensive overview over this really challenging idea of returning to practice. And I'd like to thank you for your time tonight. And I think we'll end it there. We've gone a long time. So everyone have a nice evening and stay safe. Good night.